this episode, I interview Professor Partha Kar, consultant in diabetes and endocrinology and National Specialty Advisor for Diabetes with NHS England. We discuss diabetes. I'm Dr Gail Busby, and this is I Forgot to Ask the Doctor. Hi everyone, thank you for listening to my podcast. In this episode, I'm going to interview Professor Partha Kar about diabetes. Partha is a consultant in diabetes and endocrinology. He's National Specialty Advisor for Diabetes with NHS England and co-lead for Diabetes with NHS Improvement. He's widely published and writes regularly for the British Medical Journal. He's also a prolific Twitter user where he regularly engages with his patients. I feel honoured to have him on my podcast. Partha, welcome. Thank you so much for agreeing to be interviewed.
No, thank you so much for asking. So a pleasure.
Partha, I find it really fascinating to learn why distinguished colleagues such as yourself choose certain specialties in which to work. So tell me, why did you choose endocrinology, and more particularly, why did you opt to work in diabetes care?
So basically two reasons. I think endocrinology was, in those days when I was an SHO, you had the opportunity to go through many specialties. And I think that was one, had some really fantastic consultants in those days. I remember in Worcester, specifically, I would name David Jenkins, who was a great man who inspired me to do it. So that was one. And it was a specialty which I got attracted towards. Simply because I probably wasn't that good at any other procedures, if I'm honest. And endocrinology was more about science. Diabetes was more about chatting and, trying to look at the whole patient. So probably that, I would say, was what drew me towards it in the end.
Okay, so a positive role model, a positive influence. Fantastic. So, Partha, as you know, this podcast is aimed at educating patients. And as a result, we try to avoid using medical terminology as far as possible so that it remains as accessible to everyone as possible. So let's start with the basics. What is diabetes? And can you give us a summary of the different types?
So diabetes is a condition in general, which sort of, if you make it very simplistic, where your glucose levels are high, okay? That's a sort of way of looking at it. And many different types of diabetes. The most common one, obviously, which is what we call type 2 diabetes, generally associated, not always, but generally associated with lifestyle changes that need to be made.
Mm-hmm.
It's associated with increasing obesity, not necessarily the only cause. And I must stress the point because people sometimes make it into a lifestyle disease. Not always the case, but in the majority of cases, it can be. Then you've got type 1 diabetes, which is, to put it very simply, it's nothing to do with lifestyle per se. It's got what we call, it's a process which destroys your pancreas or the parts of the pancreas produces insulin. So you end up being on insulin. So those, and your insulin lifelong, generally seen more in children, but can happen in adults as well. So throughout the sort of age groups. And to put it mildly, those are the two main ones. There are other rarer forms of it. There's genetic types of diabetes. There's pregnancy-related diabetes. But those are the two main ones, I would say.
Okay. And so what are the risk factors? So genetics is, I guess, a risk factor. And as you mentioned, lifestyle is a risk factor. For example, can type 1 be prevented? And how can type 2 be prevented or modified? Is that possible?
So, that's a great question simply because everybody's trying to find the holy grail answer to that. I think, if the narrative was as simple as, oh, if you had just better lifestyle, you wouldn't have type 2 diabetes, we probably would have cracked most of it by now. But I think science has told us it's not as simple as that. Yes, there is a higher risk when you've got an unhealthy lifestyle and, you've got higher obesity, etc. But there's a lot which is about environmental, which is about genetic reasons why you can have type 2 diabetes, if that makes sense. In type 1 diabetes, prevention is practically impossible because that's where the science at the moment is trying to find out, can you detect antibodies before? Can you give something to suppress it happening? But it's very much in research stage, very much in exploration stage of prevention of type 1 diabetes. Type 2 diabetes, going back to, which is more linked to lifestyle, there's plenty of work going on actually at the moment to prevent that. And there's national programs aimed at that, which does work. If you can sort of look at it, there's a national diabetes prevention program, But I think the main question there is about sustainability. It is about
Hmm.
lifestyle, education, exercise. Can you keep that going? So, a very long answer
Yes.
to your question, which simply put means it can be done in type 2 diabetes in some cases, not so in type 1 diabetes.
Okay, that's really interesting. And what are the symptoms? So what can people? Maybe people are experiencing certain symptoms and they're not sure. Um, Firstly, can you have diabetes and not be aware of it? Is it possible for it to be silent with there no symptoms? And if so, also, what are the symptoms? So, what symptoms might lead you to believe that perhaps you might have diabetes? Two questions, sorry.
So, so yeah, so I think, can it be silent? The answer is 100% it can. No question about it. And in fact, in a lot of type 2 diabetes, that's exactly how it is, because it doesn't really present unless you detect it, you pick it up. And then there's the extreme edge, which you mostly find in type 1 diabetes or uncontrolled type 2 diabetes, which would be linked with the, I would say, you have a situation whereby what we call they are passing water more regularly, they've lost weight, they are more thirsty. So all of those are related to. So what we do say is that if you have those symptoms, please have yourself checked out for diabetes, so to speak. So those are the main symptoms when your glucose levels are very high. But in general, it's more about, well, I would say that most cases it's not detectable. So it's good to sort of have it checked out if you've got higher risk factors, is what we tend to say.
Okay. So, and those risk factors might be increasing
So
weight,
risk factors, yeah, risk
family
factors for type
history.
2. Yeah, type 2 diabetes, family history, your genetics, your ethnicity. So I think it's more in South Asian people, people from a black community background. You would have, of course, family history sort of has a part with increased risk of type 2 diabetes. And of course,
Hmm.
your own lifestyle, your choice of lifestyle that you have. So I think all of those, and of course, increasing age as well. So it's rare, but not impossible to find it below the age of 40, but it's possible. And it's increasing more so with an increasing obesity in the population. But generally speaking, those are the risk factors to bear in mind.
And as a gynecologist, women who've had gestational diabetes, so diabetes which is diagnosed in pregnancy, which is screened for throughout pregnancy, I guess there would be another group of women who, in later life, might opt to go along and be screened. Is that correct?
Yes, I mean, not only that. I mean, I think gestational diabetes, you would probably appreciate it, is in a very interesting space where people are trying, so because the goalposts start to shift continuously. So who do you define? Because it becomes tighter.
Yes.
But you're absolutely right. One of the things we are trying to do is how do you actually get them to have their blood tests checked every year because they've got a high risk of developing type 2 diabetes. So that's always a
Hmm.
debate and how much is the science back it. But if you actually look at the 10-year risk, you've got quite a high risk actually of developing type 2 diabetes after you've had gestational diabetes. The challenge is getting the individuals and the system to check them on a regular basis. That is the challenge, I suspect.
Yes. Yeah. Yeah. And what about type 1 diabetes? So does that usually show up in childhood? And how does
Yeah, I mean,
that
generally
show up? What should parents look out for?
So generally speaking, type 1 diabetes will present in the younger age groups. But having said that, there is a significant amount of diagnosis now, nearly 30% or more, which is above the age of 40. So there are people who are being diagnosed much later in life. So you've got examples such as, well, the former Prime Minister Theresa May is a very good example where she was diagnosed much later. But it is
Right.
there. It tends to happen. And again, the risk factors are there. There are lots of odd risks being done by association. What is the child risk if you develop diabetes before a certain age, after a certain age? But it's all in conjecture territory. It's very much sort of like, okay, you've got a higher risk. That's where it sits at the moment.
Right. Okay. Thank you. And what about timescales? Is the time frame between perhaps having symptoms and being diagnosed important? Should people who are listening to this and are worried, well, I am passing urine a bit more regularly, more frequently, and I've been to my doctor and they've tested and it's not an infection. Is the time frame important? Should they go along quite quickly to be diagnosed? Is it something that they can kind of watch and wait?
Yeah, I mean, I think that it's the association of symptoms. So if you've got, you're passing urine a lot and you're losing weight, I think without doubt you should straight away go and have your levels checked if your glucose level is up. And that is not even a blood test, it's a simple finger prick test to tell you what's going on, right? On the other hand, the more subtle varieties where you are sort of like, oh, maybe I'm passing a little bit more water, may not have it. I've got risk factors. I come from a South Asian background. My weight is not the greatest. So you can have the check done. So you'd have got what we call HbA1c, which can be done, and they're done above 40 in lots of age groups, higher risk factors. So that's something which we would advise that if you're worried about it, you've got a family history, you've got early sign, by all means have that done. But there's a degree of urgency around it depending on what other symptoms are present with it.
Okay, brilliant. Okay, so basically, if you're unsure, go along. It's a
Yep.
straightforward test. So that brings me on to my next question. How is it diagnosed? Are there different ways of diagnosing? If I do
Yeah.
go along, what can I
Mm.
expect my GP to do?
So, to be honest, most high street pharmacies can do it nowadays. You don't even have to go there. I mean, if you go and ask,
Oh,
people will
wow.
do sort of checks for diabetes. So lots of people are aware of the need for doing it. And I think we all are quite careful about is not overloading our GP colleagues even further in the present environment, right? And you wait for that. So
Yes.
I would say it depends on the urgency. I go back again. So if you're worried about you've got high risk factors, you're not quite sure, and you're in the age group and you're thinking, could it be? Then the test to do it is what we call an HbA1c, right? Very straightforward lab test, and there's certain levels. If you're below it, you don't have diabetes. If you're above it, you have got diabetes. Now there is a certain age range or a certain level range. We might say, you are what we call pre-diabetes. So you've got a higher risk of developing, and that's like a warning bell. You really need to change your habits and your lifestyle and all that sort of stuff. Then is the urgency factor where, as I said, you're losing weight, or you got a child who are losing weight, going to the toilet a lot, drinking a lot of water, those combinations of those three things. In which case, I
Yeah.
don't think you should sit on it. I think you should straight away. That is an urgency which needs to be seen by a clinician. And as I said, it's a very simple, it's not like sending a blood to your local lab. That can be done, just by pricking a finger, giving a number. And if you see it's in double figures, etc., you straight away know, and you go from there. So yeah.
Okay. And tell me, Partha, why is diabetes important? Why are we having this conversation? Why is it such a massive thing on the national agenda? What are the complications? So why is it important to have it diagnosed? Can you
So I
explain?
think, yeah, I mean, I think it's fair to say it probably affects everything one way or another, right? And I think it's the length of it and the control level of it which does. So you name an organ, it affects it. It affects your eyes, it affects your kidneys, it affects your feet. And in the bigger ones, if you've got type 2 diabetes, you've got higher risk of having a heart attack and a stroke. So it increases the risk factors for so many, what we call organs being affected and thereby compromising your well-being. And on top of that, obviously, if you got then issues like pregnancy, etc., that makes it even more complicated. We know the importance of that. If you've got infections, it takes longer to heal. So all across the board, let's just to put it simply, higher glucose level, higher sugar levels of your body is just not good for you or any part of your body. And that's what it is. It affects everything, so to speak.
Okay. And you mentioned that the important things are how long it's been around and how good the control is. Can we extrapolate from that if you do control it well, then you can avoid these complications or at least mitigate them?
Oh, without question. I mean, there's some landmark studies. Without going too much into detail, if we had to pick one study, we call it the UK-PDS study. That's a big gun study done in 1998. And the interesting thing is, it says that initial few years, if you really try hard and get good control, that effect of that stays on with you. 30 years later, it's
Okay.
still there in the system. So I
Wow.
think that's an important message which we say to everybody, come on, let's get it done at the beginning. Don't let it drift. So the longer you have it, okay, there's a slight thing of closing the stable door after the horse is gone. When you've got first 10 years, it's all been wrong, and then people have a complication, then they're really interested in trying to get on top of it.
Yeah.
Our advice always is, hey, listen, just do it at the beginning. Then you won't have any of those to worry about. So that's pretty much the message.
And that's a really, really important message. I mean, I'm also a pediatric gynecologist, and I know that certainly in my area, neck of the woods, medically speaking, that sometimes during the teenage years, Teenagers with chronic disease can sometimes kind of say, "Oh, I have no time for this," because they're so busy exploring other things, and they're finding themselves. But that's a really, really important message, that those early years are so important and so significant.
Yeah, I mean, I think if you want to pick a Achilles heel in the diabetes setup in this country, then it certainly is in the transitional age, which we say, once they're
Yeah,
switching over into that age of teenage life and college life, uni life,
yeah,
clubs and all
yeah,
that, drops down the priority order, understandably. And you want to fit in, you don't want to be going around doing
yeah.
sort of injections and stuff. It's a very tough space. So I think we all try our best to try and, cajole people to sort of say, look,
Or
listen, this is a very important time. Yeah.
Mhm. And that's a really important message, that how well it's managed initially stays with you for the rest of your life. That's really, really a powerful message. Okay, so getting down to brass tacks, then, what are the available treatment options, and how effective are they? And do people have several options? What are they likely to be offered? What is likely to be discussed?
So, if we divide it up, type 1 diabetes, the treatment is insulin, straightforward as that. And there are very different
Yeah,
forms of it. Insulin that lasts for a day, insulin which is short acting with your meals, mixed type of insulins. And to be honest, they're all available on the NHS, and you should be
yeah,
available to have those. The debate that needs to happen is, how do you give the insulin? Do you give it through the traditional way of a pen, or do you do it through a technology like an insulin pump? That's the sort of modernization of that treatment delivery system is going. But beyond that, in type 2 diabetes, obviously it starts with diet, exercise, which is still the sort of cornerstone. And after that, the treatment, we've got a series of medications. You start with metformin, and there are much more newer drugs which have come through, which are quite exciting. And I think the exciting bit is that all the studies are showing that these newer drugs actually have got impact on the end organs, irrespective of the glycemic control or the glucose control. It's not only does it lower your glucose, it helps you lose
yeah.
weight, and it's to improve your risk
Wow.
of having heart attacks, and improves your kidney functions, and all that is very exciting. Heart failure. So those drugs have suddenly appeared on the market, where you're saying that if you're on these drugs, then forget about your glucose control. It will do it anyway. It also improves your risk of having heart failure and kidney failure, which is quite powerful. So exciting space, exciting times in the
That's
world of
amazing.
diabetes.
And are these drugs currently available?
Oh, absolutely. They're all available, all nice endorsed. I mean, everything's available on the NHS at the moment. So yeah, fully on. If you're there, if you're not having it, you should be looking at being on it if the control isn't good enough. So yeah, absolutely.
Okay, and I've seen a lot on Twitter about the insulin pumps. Are they like the gold standard these days, or is it that it may agree with one person and someone else may prefer a different preparation?
No, the majority of people are still on what we call insulin pens, right? And it's a delivery system. It's more clunky, but they're getting better. So I think the insulin pump, the way to see it is, it's a different delivery system of insulin, and I think they're
Yeah,
getting more modernized. The smaller, they're getting easily connected, and I think all those innovations will drive people towards it, because it's got to be an innovation that people like, if that makes sense.
yeah,
So
yeah.
majority of people still on insulin pen at the moment, but it's moving definitely in the right direction.
Okay, but an insulin pen can adequately control your diabetes.
Oh, by the vast majority are on that, do very well. I've got patients, loads of people who are just on pens. I mean, the new thing that has happened is all these sensors that people talk about, where you don't have to prick your finger anymore. That's the big exciting thing. And
Oh
once you've got an
wow!
idea of that, glucose levels, you can absolutely do it with pens, and most people do. So yes.
And are people's insulin requirements pretty stable over time? Or does it require a lot of, so it requires monitoring, doesn't it?
Oh, absolutely. I mean, there's so many
And does
factors.
that
I
involve
mean,
finger pricks several times a day?
so you used to in type 1 diabetes, for example, you had to prick your fingers 6, 8, 10 times a day, and lots of people would struggle with that simply because it's so difficult to do. So we have now moved
Yeah.
towards a non-invasive, what's called Freestyle Libre and Dexcom. And in simple, plain terms, I always say that if you look at diabetes or type 1 diabetes to begin with, there are three things you need to do, which is prick your fingers, look at the number, do some mental maths what to do with the number, and then give yourself some insulin or glucose to counter it, high or low.
Yeah.
What technology is moving towards that we will try and automate them all. That's what technology is going to. So you don't have to prick your fingers, it will automatically appear. And then you've got algorithms coming up that will do the calculation for you. And then you've got modern insulin pumps which will deliver the insulin for you. So you can see everything is becoming easier. That's the sort of
Easier.
means towards, yeah, the quality of life. That's the main push behind it. Will just improve your quality of life.
Absolutely. And so the fact that everything is becoming easier, do you think that complications or serious complications are becoming rarer? Is it
Absolutely. I mean, if you look at the
translating into better outcomes?
if you look at the data, I mean, in the NHS, right, cardiovascular deaths are deaths due to heart attacks and strokes are no longer the top reason for dying if you have diabetes. So it's come down really. Blindness, diabetes used to be the main reason for it. It's not anymore.
Yeah.
Amputation rates
Wow.
have dropped, hospital admissions have dropped. So the NHS as a whole has done really well in diabetes care. So, and if you look at international data, we do really well. So, and I think that's the testimony to modern science and how people have embraced it.
Mm.
So, definitely going in the right direction in this country, no question.
Okay, brilliant. Okay, so thank you for those really, really clear answers to my questions. As you know, I ask listeners beforehand if there's anything that they'd like me to ask on their behalf. Is it okay for me to ask a few questions that have been submitted by our listeners?
Absolutely, go for it. Let's see what we got.
Okay, perfect. So I must stress at this point that it is very difficult to give specific and personalized advice to patients without a thorough knowledge of their past and current medical history, examination findings, and investigation results. Also, due to time constraints, I have summarized the questions in a way that I think retains the essence of what is being asked. Therefore, these answers should only be used as a guide, and individualized care and medical management should be sought from one's own doctor. Okay, so we've got quite a few questions for you. So the first question is, if Partha had type 1 diabetes, what treatment monitoring combo would he pick? And our listener says, I'd choose, this doesn't really mean much to me, I'd choose G6 Tandem T Slim and Control IQ given a choice. That's a bit like Greek to me, Partha.
Mm-hmm. Yeah, so I'm going to answer this question without naming any company products. Okay, so I think what you just said was Greek with
Okay.
different company products, and I'll tell you why. Because I can name it. I think, but the reason I won't is because I do a role whereby I have to work with all the companies, and if I come out with "here is my choice," suddenly it becomes unfairly an advantage
Yes.
for that company. I'll tell you what I would want. I
Yes.
would want not to prick my fingers, right? So I would want to be on a sensor, right, whereby it's done automatically. Number one. Number two, I would like to be, I just said, I want the mathematics to be taken out of my head. I don't want to sit down and look at the number and go like, ooh, I need to think about what to do. And I don't want to go to
Yeah.
the hassle of trying to inject myself with insulin. Now, that's to me is a lesser of a problem. I would like to see the numbers. I'd like somebody to do the maths for me and it would be brilliant if somebody delivered the insulin for me. So I would rather be on that in an ideal world. Okay. So everything automated is what I would like to have. I would also like to have something which doesn't interfere with my life. Okay, which basically means that I don't want something clunky sitting on me, right? Which sort of gets caught up in something I really can't do it. So the simplistic answer to the
Yeah.
question that's been asked without naming any company products is I would like to be on
Hmm.
something which is automated for me completely. And I think the listeners will know what I mean without me naming products.
Okay, great. And that's what we're kind of moving towards, I guess you said before. That's like the
Absolutely.
goal.
And I'll say one
Okay.
thing, Gail, is that I think people always ask me, what is your drive? Why do you sort of push for technology? That's exactly the reason, because that's what I would want, right? That's what I want my
Yes.
loved ones to have. So, touch wood, if it doesn't happen, of course. But if it did happen, many of my children had type 1. That's what I would like them to be on. And my view is, if I want my child to be on it, then that should be available for every child and every adult. So that's my way of looking at it.
Absolutely. Well said. Absolutely. Okay, so the second question is from a listener who says that my 26-year-old son is asking whether any children that he may have are at greater risk of developing type 1 diabetes. The listener says he
So,
was diagnosed at 9 years old and there's
mhm.
no history of diabetes in the rest of the family.
Okay. So there's actually a really good piece of information he can look at. So my suggestion would be the American Diabetes Association has a web page which is called the Learn the Genetics of Diabetes. All right, if you Google it, you'll find it. It's the American Diabetes Association, and also Diabetes UK have got it, JDR have got it. But the American Diabetes Association very clear about your risks depending on when you were diagnosed at what age group. Okay. So, of
Wow.
course, and it gives you what is the risk? What is your risk? 1 in 100, 1 in 10, 1 in 4. So I would suggest have a look at it. I can read it out for you, but that probably won't be useful. But for the listeners, I would say that the American Diabetes Association, the page which does the genetics, it actually divides it up, which is definitely worthwhile looking at. That's what I would say.
Okay. And just to help our listeners, I will put a link to that page with the podcast so that they can click the link, hopefully, and it'll take them to the page. Thank
I
you.
mean, if you
That's
want
that's
Gail,
really, really useful.
if you want Gail, I can read it out. It's not too long, so that might help if say anybody's listening, if they would like to sort of have a look at that.
Yeah, go for it, please. Absolutely.
Okay, so if my memory serves me right and everything, if you are a person with a man with type 1 diabetes, the odds of your child developing that is about 1 in 17. Okay, if 1 in 16 or 1 in 17. Here's where it gets even more sort of complicated, because if you're a woman with type 1 diabetes, and your child was born before you were 25, okay, so the person is 25.
Wow.
The child's risk is 1 in 25. If the child was born after you turned 25, your child's risk is 1 in 100. See, I told you it's not easy, but you need to sit down
Wow,
and
that
write
is.
that down and see where you sort of get to. But in short, the age at which the child was born and your own diabetes, whether you're man or woman, makes a difference in your risks. So it could be between anything from as 1 in 17 right up to 1 in 100. How's that? Not
That's
easy.
amazing. So a diabetic, if I've heard you correctly,
Mm.
so a diabetic woman
Type
who has a
1, yep.
child after she is 25, that gives a low risk to the child. Wow.
It's interesting, isn't it? Really interesting.
That is that after 25 the risk
I
goes
think,
down, right?
yeah, sorry, 120, 100, yeah.
Yeah.
So
Sorry,
it's.
I'm amazed by this information.
I mean,
Right.
I said,
Okay. So maybe delay.
having children after
Sorry.
25.
Yeah.
I mean, again, the thing is, I don't recommend it, if I'm very honest. I'll tell you why.
Yeah.
Because because there used to be a time, Gail, where women were stopped from having children, full stop, if they
Yeah.
had type 1
True.
diabetes. We have been through that. And I have
Yep.
patients who are now really, in their older ages of life, who have regretted not having children. And that was done to them by
Yep.
clinicians, rightly or wrongly. And
Yep.
the reason I say rightly is because in that time, that's the information they based on. It's not that they were trying to make people not get pregnant, but the message was, hey, look, your control's not good, don't get pregnant. The long-lasting
Yes.
impact of that is pretty devastating for the woman concerned, I would say, because 20 years down the line, she's going like, well, that wasn't true, and I've lost my chance to have a baby, so that's not right. Which
Yes.
is why I never say to anybody, don't, if that makes sense, right?
Hmm.
I think
Hmm.
these are
Yeah.
all studies, these are all papers which are not in the sense locked in stone, which is why I don't give out these sort of figures all the time. I sort of say, look, there is a risk, here is a risk, there is a risk. You need to fit it in with your life, right?
Yeah.
Some women would
Exactly.
like to. So that's what I'd say. I'm very clear about never obstructing people from going ahead and living their life, if that makes sense.
I agree, particularly with having children as a gynecologist. I couldn't agree with you more. However, it is really, really valuable to have that kind of information that you can weigh up in your own life and use it as you see fit. Wow, that's.
Yeah, and you
I'm
have
really glad you went on to.
yeah, it's the American Diabetes Association. That web page is quite informative. I sort of tend to give my patients a link from time to time. Will I have a look at it? It's there. It's there
Yeah,
on a validated web source. It's up to you to use that
yeah.
information as you wish to.
Okay, perfect. Okay, so moving along, and the next two questions are kind of similar. So the next question is, what is the role of a low carb diet in managing diabetes? And
Okay.
then I'll read the other one. A bit of background, this patient says, I was diagnosed in 2012, age 62. I have adjusted my diet enough to have a score of 45 last time my blood sugar was tested. I am told if I maintain this level, I can be considered in remission. I hope to do this. I will
Mhm.
follow dietary advice and take exercise in the hope of going into long term remission, or ideally reversing my diabetes diagnosis. Can
Mhm.
I expect my GP to supervise this level of intervention? Up till now, the advice has been vague, mainly saying eat little and often. You can eat carbs and a little of sweet foods, just not too much. Would you say this is safe? So, a bit of advice around diet in diabetes, type 2 diabetes.
So this is one of the most emotive subjects that people get embroiled in, right? And it's
Yeah.
diet is a incredibly emotive subject because people believe in it so much to an evangelical degree, and they form camps: low carbs, low calories, Mediterranean, etc. I've got a very simple
Yeah.
view: do the diet that works for you. There is no one diet that is better than the other because it depends on the affordability, right? The best diet in the world is the one you can afford. From a degree of privilege, if you can afford a low carb diet and more importantly, maintain it,
Mm-hmm.
it works just
Go
like
for
any
it.
other diet works. So if you look at the randomized controlled trials of the science, then a low calorie diet works as well, right? That's the sort of big trials done by Roy Taylor and their group. It shows about remission, putting diabetes. That's why you have the national programs. I've also got patients who tried low carb and done really well. And my view to that is good on you. It works for you. Good on you. But don't force it on anybody. I think that's important. And I think that's where the diet wars become so emotive because you believe that person should do that. And you go like, and my view is, but you don't live their life. You don't know whether they can afford it. And even if they do, can they afford it more than 10 days? That sort of stuff. So I think that's what people need to be
Yeah.
aware of. So that's the first question. And if people really want to take a step back from the debate and have a look at science, there's actually a paper done by Public Health England which looked at low carb diets compared to other diets, and it said it pretty much was the same across the board. The basic message was, can you maintain it? Right? Because
Mm-hmm.
the
Yeah.
after 1 year you can see people coming off it, after 2 years. So that's the sort of thing. So I'm very relaxed about diet. I do not think there is only one diet. I think there are many diets. If you can afford it, if you can sustain it, if you can tolerate it, and it works for you, please carry on. That would be my view. And the other question, can my GP supervise it? Well, I think that sort of role is probably off the dietitians to try and help you, I would say, rather than GP's role in that case would be just to keep an eye on your HbA1c and see that you stay in remission, I would say. I tend to stay away from the term reversal. I always give the analogy of what our oncology colleagues do in cancer. They don't say it's gone forever, ever. It says it's in remission. You keep an eye on it all the time, because if you believe that you put your type 2 diabetes into remission and then you can go and change your lifestyle back again and everything, well, no, it's going to come back.
It's
So
going to come back.
you need to continue that to stay there. That's the message.
Perfect. And do you think that exercise is equally important?
I think exercise is important, full stop. WHO recommends what we should do. I think, again, exercise is about what you can fit in, what you can do. I think people
Yeah,
always
it's the
say,
same
again,
thing. Yeah.
it's the same thing. I think what happens with these things, you will have somebody with so much passion, and I have got plenty of time for people who come with that, but you must, Partha, you should run every day. And my answer is, I would love to, but I just don't have the
Yeah.
time, right?
But when?
And by the
Yeah.
time I get home, yeah, and the time I get home, I'm so knackered. I can't. I would love to. I know what it's. So I think exercise is important for cardiovascular wellness and everything. If people know that, it does help you lose weight if you do enough. But fit it around you, fit around everything you can do. We know what's, and on this message, people are not, the public are not stupid. The public knows what they need to do. Sometimes circumstances and life
Yes.
gets in the way. So,
Yeah.
you need to respect that.
Absolutely. Well said. Well said. Okay, so now we get a little more technical, I guess, about
Mhm.
systems.
Hmm.
Can you ask Partha what he thinks about the new integrated care boards and whether they need reforming so that patients in England receive uniform treatment when it comes to diabetes services? Also, should all type 1 diabetics have access to a pump should they wish to try it?
So, first question is more political. These are the restructures of the NHS,
Yes.
which, well, you and I will know. We go through this every few years. Politicians change, politicians have whims, and they feel that they can tinker with it. And believe you me, to those who are listening as clinicians, we just want to be left alone so we can do our jobs. But such things don't happen. So, will they be a good thing? I don't know. There'll be many iterations of it. I don't think it depends. My view is, I don't think it depends on the structures. I think it depends on the leaders who are leading them, right? That's
Other
my view.
people.
My only thing I would say is that, and I've got a very simple analogy: bad wine in new bottles is still bad wine. So just by changing the structures, you're not going to change the outcomes. You need different leaderships who understand what you talk about, work to a set of rules across the country. And you're absolutely right. Why should area X and area Y be fundamentally different as to how they develop care? Shouldn't in one place, but they will, because everybody's got different views as to how they do it. So to your question, to whoever's asked, I think it has got potential, definitely, for people to sing from a same hymn sheet on the main priorities, whether it's oncology, whether it's this, diabetes, whatever. But they need the good leadership and the leaders in place to sort of be open also to the idea that I can learn from other areas. And that's not necessarily the case in the NHS. So I would say there's a mixed response to that. To the other question, should it get to a position that everybody with type 1 diabetes should have pumps? That depends on what NICE says. At the moment, that's from 2008, NICE says that according to the evidence, because we as a system, we are a tax funded system, we can only use money which are cost effective. And that's the right thing to do because you're trying to give it to the whole population. At the moment, NICE says
Yes.
that there are certain groups of people who should get it. But we have asked NICE to review it in light of, it's been 14 years since that has come through. That should come out next year. That will be what we call the more modern pumps, which are the artificial pancreas, the pumps talking to sensors, all very Star Trek things. But we'll find out what NICE says. And I think if NICE looks at the data and says everybody, then the onus is on the system to make it everybody. If NICE says, well, actually, the evidence says it should be for certain groups, then it will be for certain groups. And finally, should it be for everybody, if you ask me, right? The answer is yes, of course it should,
Yeah.
right? But will we be able to afford it in a tax-funded system is a different matter altogether. And I think that's a very different space as to what I as a clinician feel, and whether it's affordable on a tax-funded system are two very different matters.
Yeah, because there are many competing pressures on the NHS and on the funding, aren't there?
100%. 100%.
Yeah. So the next question is kind of similar. So it says NICE guidance has recommended continuous glucose monitoring for all children and young people with type 1 diabetes. Do you think there should be a standardized way of funding this, again to funding, and a national implementation process, as certain trusts and integrated care boards can offer this, but others are not sure how to proceed? Is it down to individual trusts to sort it? This may lead to inequity in those getting CGM, continuous glucose monitoring, and has done. And this colleague, I think, says the background is that neighboring more affluent areas with less ethnic diversity have commenced implementation, whereas our patients who are deprived and ethnically diverse do not have ready access because the ICB is unsure of how to implement. So it's a
So
long
many
question.
layers. Yeah, many layers. I'll try and answer it as best as I can. So, first of all,
Thank
NICE
you.
have said that CGM should be available to everybody with type 1 diabetes, not just children and young people, everybody. Okay. So
Right.
let's make it very clear. At the moment in this country, if you combine what we call different types of non-invasive sensor, nearly 80% of people are on it. So most areas have done it. Now then we come to the issue of continuous glucose monitors. Okay. There are two reasons for using a continuous glucose monitor. One, just to check your glucose, right? If that's what you want, then it's already available at same price as existing products. Where I work, if you want it, come and get it. It's as straightforward as that. Okay, that's how it works. I write a prescription and off they go, and it's there. Done. There is another reason why you use a continuous glucose monitor, whereby you want it to connect to a pump and make it into one of those Star Trek things that I just described. For that, we'll have to wait till NICE reviews the evidence. And that is happening, hopefully, the final version at the turn of the new year, where we will know. So that's the position of that. Will there be funding? Well, there is already funding. As I said, majority places are funding it. And there are some areas which are behind. There is variation. But I go back to the point that we talked about leadership. And leadership is not just a system leadership. It's also about clinical leadership. So people, when they come to me and say that, can I get X and Y? The answer is always yes. So my question back to other clinicians is, if I can do it, so can you. And that's not because of my position. Let's forget about Portsmouth for a minute. If you go to Coventry, you'll get it. If you go to Derby, you'll get it. If you go to parts of London, you'll get it. But we've had to battle with, for example, Cambridge. Cambridge have now accepted that, and Cambridge are going to do that, Norfolk, but they have taken their time. So the question is, why is it in a country, it's not a huge country really at the end of the day, when you compare it to many other countries, you can go into certain areas to get it, certain areas not. And I think that boils down to local leadership, so to speak. So that is what I would say, but it's getting there. We have made huge strides. And I think just to put it in context, Gail, recently I was at an international conference. At the moment, the NHS provides more technology in type 1 diabetes than majority of countries across the world, and we are one of the few people who are tax funded. So I think that's also something to celebrate, but there's much to do still. Indeed.
Okay. So hopefully in time, I guess,
Yep.
It's a time thing, it's a political will thing, but basically individual trusts have to stand up and, implement it.
Yep. Absolutely. Absolutely.
It's not going to be shoved on them. Okay. Next question. What are the steps being taken to look at reasons for inequality in technology access or refusal for ethnic minorities and those in deprived areas?
So I think we should, first of all, Gail, I would say to all the listeners, we should not equate deprivation and ethnicity together, right? There are intersectionalities between them. Not every brown child is poor. Not every white child is rich, okay? And vice versa. We need to be very clear about it. So let's break it down. So first of all, let's talk about deprivation. You're absolutely right. The poorer you are, the lesser your chance of getting technology. We have closed that gap in flash glucose monitoring because we have given it out to so many. You just cut across all the deprivation quartiles. There is a problem with insulin pumps. And I think that's not because people are doctors and nurses are just elitist people, don't want to give it out to the poor people. It's because of the systems we set. For example, if you want somebody just to go to the hospital to get technology, then a mother who's on a 0-hour contract and working to put food on the table for our children, she doesn't have time to attend your hospital visit. So clinicians need to be aware of those dynamics. We all live a life of privilege, and it may sound odd to you that people are not coming to see me. How dare they? How dare they? Well, they can't come to see you because they don't have the money to pay for the car park. All right. So do something about it. Try and see what you can do in the evening. Reach out to them. Go out and do it closer to them. So that's that bit on deprivation. And there is work ongoing to and I'll come back to that in a minute about the work. Then you come about ethnicity, and there is a big gap. There's no question. If you're a black child, you've got half the chance of a white child, okay, of getting technology in the NHS, right? That's an unacceptable position. Is it just poor? No. Let me break the data more for you. For a black child, whether it's rich or poor, it doesn't matter. You still don't get it, all right? The poorest white child has got more chance of getting the technology than the richest black child, okay? So it's uncomfortable to listen to, but that's the data. Now, if people say to me, why? I will tell you why, because I do a role. That's because there is plenty of bias in the system. Clinicians immediately, whenever you say that, go, well, we can't possibly be racist and stuff. It's not about that. Whether you are or not is an irrelevant point to me. But the point that I always make to people, maybe you are, maybe you're not. That's not for me to judge. But I tell you what, now that I've given you the data showing that there is a problem, if you haven't broken every sinew, stretched every sinew you have to try and close the gap, you need to tell me what you are. That's my view. I don't label anybody. I think people might need to, is it cultural issues? Is it because people can't speak the lingo? Is it because you're talking in a different cultural thing? I don't know. Find out, do something. So, to the last bit, what are we doing about it? We are going to pick 20 to 25 centers, which we're in the process of finishing, which have got the widest gap as regards access to technology goes in deprivation ethnicity, and we're going to give them some money. Not to just get another nurse or another doctor. I want them to try different things, cultural awareness, programs, do something different to close the gap. What I've also told them, some of them will fail because we don't know what works, but I want you to use the money to try and do something different. So hopefully we'll be able to learn from that. And I think that's my view. So it gets into a very emotive space whenever you talk about these things where people are defensive. They go, like, well, we're not racist. Okay, just take that aside for a minute. That's the data. Correct it. Do whatever you want. Maybe it's unconscious. I don't know. Just now that you know about it, stop being unconscious. Just sort it. So that's my view on that.
And is there an increased incidence of refusal to use this technology by ethnic minority population? Is that a factor? Is it they're equally
no,
accepting of the technology? Because
not
just because that's
necessarily.
in this question.
So I think there's an interesting analogy here, and this is more anecdotal, which is what I must say, is that a lot of things depend on how you sell it, inverted commas, to the patient.
Yes.
If as a doctor, you want to just make it as part of your, you know what, you put all the effort to say you must have this. But if you come in with a prejudged notion, right, that this particular family, don't know whether they can have it, they come from let's pick, they come from a Muslim background, are they educated? Would they be able to do they know maths? Why have you made that call? If you're prejudiced that in your mind, then you have not taken it further. That's my point. And I'll give you one example. I met a black lady this morning who I asked why she wasn't on technology. She's a young girl. And she said, because they said that it could stop and I might die. And I spent about half an hour going like, no, it's not that. And my immediate reaction is that it's from a department where I know lots of people get it. So why have they said it to her, but not to anybody else? Why have you gone with a different narrative? And those are the things which we need to explore. And I think people need to be open about saying maybe we do have biases in ourselves which is causing these gaps. It's not about, a black person or an Asian person doesn't want the device. It's about, have you sold it to them as part of your standard care? So that would be my view on it. So it's a very emotive area, but as I said, data is what it is. If you don't like the data, do something to sort it. Don't come at me. Just sort the data.
Yeah. Okay. And our final question from listeners is: do you see a change in how people will access care for diabetes in the future? That's a wide open question.
I think they will. I think I've always said diabetes sits on three planks: self-management, peer support, and access to trained professionals. And the last one is in trouble all across the board in the health system because we don't have enough of them. I think more and more people will depend on peer support. I think that's what will happen because lots of people will start offering advice in a chronic disease space, especially with technology. And I think lots of things will also go to the high street, the pharmacies, etc. That's what will happen. But I think peer support is where a lot of the diabetes care will shift to. That's what I would say. That's what I think is where we are going to.
And do you think that poses a risk?
100%. 100%. To an extent. I think unregulated anything is always risky. Peer support can do a fantastic job in supporting. Can they do the work which a clinician would do? I don't know. We'll find out. I don't know. There's the answer to that. But I think we are in a very tough space right now in healthcare. And I think that's what people need to realize is that. So when people phone up your doctor or your nurse, going, I can't believe you haven't called me for 3 months or 6 months. It's not because they're twiddling their thumbs. We are overrun at the moment. So that's what I would say is where is a risky bit, I would say, going forward.
Okay, thank you. Great answer. Okay, so those are all the questions from the listeners. I've got one last question to ask from myself.
Go for it.
You, Partha, have seen many, 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 many patients with diabetes and managed them in your career thus far. Given the opportunity, is there anything you'd like to say to people who think that they may have diabetes or have been diagnosed with diabetes?
So I would say that always take a step back and think about what you can do to counter it. If you've got type 2 diabetes, right, and you're worried about it, have it checked.
Yeah.
Can you put it into reversal, remission? Try it. There are means and methods out there. Science has progressed to a point where there are really good methods of trying to either reverse it, put it in remission, or indeed, if you can't, other drugs to help you have a good, healthy life. If you've got type 1 diabetes, again, important to remember, it's one of those things which has happened to you. It's not your fault. You don't need to sit down and think the technology is there to try and help you, and there's plenty of people to help you. So I think you can't change the past, but you can use the present to make the future better, is what I would say. That's my message to everybody. And I always leave that with hope as much as possible. So, and
Yes.
final bit I would say is that, don't judge another person who might have diabetes by your own parameter. That's what I would say. Don't compare yourself to another. They might have a different set of life, rules and regulations which you don't have. So that's my message to everybody, I would say.
It's a fantastic message. And I have to say, as a clinician, I don't work directly in diabetes, but certainly you cannot avoid diabetes in whichever field of medicine you end
Yeah.
up working in. And I have to say that talking to you, I'm so encouraged that things have changed and gone such a long way from, for example, when I was training. It's an entirely so really, I think the outlook is really, really positive. So, in closing, Partha, I'd like to thank you so much for coming on to my podcast and sharing your vast knowledge and experience with us today. Thank you so much for supporting me in this venture to try to educate patients. And most of all, thank you for your tireless work and dedication in the field of diabetes. You've changed so many lives for the better. And actually, when I put out on social media that I was going to interview you, a woman got in touch to say he cares so much about his patients, and I just thought that was lovely. I thought I'd leave that with you. Thank you so much.
Thank you. Thank you.
Thank you for listening. I hope you found it useful. Please keep your eyes and ears open for upcoming episodes. If you enjoyed this, please hit the like and subscribe buttons to raise awareness of this podcast.